Good afternoon, everyone. Welcome to CAQH Core's second town hall of 2023. We're glad you're all able to join us this afternoon. My name is Jackie Leiser. I am a manager on the Core team, and I'm going to kick us off today with some brief logistics before I run into our agenda. So just some quick notes. If you'd like to access today's webinar materials, you can do so right now. If you take a look at the handout section of your GoToWebinar menu, you can download the presentation slides. We'll also be sending out a copy of the slides and webinar recording to all attendees and registrants in the next 1 to 2 business days. We also want to encourage you to ask questions throughout the presentation, so you can do this at any time using that questions panel, again, on the right-hand side of your screen, and we'll have some time for Q&A as we get later into the presentation. And I think that's it for logistics. If we look at the next slide, I'm just going to run through our agenda quickly. First, we'll go over a brief CAQH Core overview. We'll then talk about federal regulatory activity since our last town hall. We'll then dive right into 2023 operating rule development. So you'll hear a bit about what our team is working on and what's to come later on this year. We'll provide a brief overview of future visioning for CAQH Core and what that looks like over the next few years, and then we'll wrap everything up with a call to action. I'm going to go ahead and pass things off to Erin Weber, who will get us started.
Great. Hello, everyone. Thanks so much for joining us today. I'm Erin Weber. I am the Vice President of CAQH Core. I've been with the organization for more than 13 years now. I am joined today by my colleagues, Michael Phillips and Pete Benziger, who are both senior managers on the Core team, leading a lot of our rule development efforts for 2023, which they'll share with you later in the presentation. I'm going to start off today, though, describing who Core is, how we fit into the broader healthcare ecosystem. So if you are someone that has been working with us and known us for years and years and years, I give you full permission to tune out for the next 5 minutes, and then we'll get back to all the new and great stuff that we're working on specifically this year. CAQH Core is an initiative of CAQH. We are a nonprofit with a mission to drive the creation and adoption of healthcare operating rules. And I'll talk about that in a minute, but operating rules really help drive interoperability and data exchange between providers and payers and consumers. CAQH Core first started developing operating rules about 15 years ago, shortly after HIPAA was passed. The electronic transactions that were named under HIPAA to support healthcare billing and payments. As these electronic standards were implemented, there was still a lot of lack of uniformity in how the standards were being used and exchanged between providers and payers, which made it really difficult for them to automate their systems. So the industry came together and created Core, modeled after the financial services industry, which has developed operating rules for things like the ATM network, where you can go anywhere in the world and your bank will talk to another bank and you're able to take out money in real time. We were modeled after the financial services industry and came together to develop operating rules on a voluntary basis, and those were showing significant ROI, reduction in denials. And so that caught the attention of the legislative process, and the concept of operating rules was included in the Affordable Care Act, and Core was ultimately designated by HHS as the National Operating Rule Authoring Entity for the HIPAA-mandated administrative transactions. We see our role in the industry not only to bring organizations together to develop and debate and vet operating rule requirements, but also to support the implementation of operating rules through our certification program, through our ROI and measurement initiatives, as well as through our education and outreach efforts like today's webinar. On the next slide, I just want to quickly highlight our participating organizations. It's a really diverse group. So you can imagine that when we have a subgroup meeting where we're talking about potential operating rule requirements for prior authorization or value-based payments or claims. There is a wide range of perspectives and opinions, and I think that's what really sets our work apart, is that organizations are having these difficult conversations and ultimately coming to consensus on an approach to address industry challenges. On the next slide, a little bit more around what an operating rule is. The Affordable Care Act defines operating rules as the necessary business rules and guidelines for the electronic exchange of information that are not defined by a standard or its implementation specifications. So that means that an operating rule cannot duplicate what is in a standard, and it cannot conflict with what is in a standard. Operating rules are really intended to enhance and build on the standards to make them even more valuable for the industry. They're really common in other industries as well. We talked about financial services, but transportation, retail, all rely on operating rules to help govern how information is exchanged. At CORE, we develop really two types of operating rules: data content operating rules, which govern the information that is included within a standard transaction by making maybe optional data elements required because they add value, or using a certain data element field, requiring certain data to be included in a more optional field. And then infrastructure requirements support how and when a transaction is sent. So there are requirements around real-time transactions, connectivity requirements for a common method to exchange the transactions. So lots of variety in operating rule requirements. And you can see on the next slide our full set of current CAQH core operating rules. We have 8 sets of operating rules that organizations can get certified in, 3 sets of which are federally mandated for eligibility and benefits, claim status, and payment and remittance advice transactions. We are always developing new operating rules, and you can see each set has a set of infrastructure requirements and connectivity requirements, and then there are more additional rules that are unique to that specific transaction and its needs that have been built out over time. Next slide, please. I mentioned our core certification program a few slides ago, but any organization that exchanges these business transactions can become core certified, which means that you have demonstrated that your IT system or product is operating in conformance with the operating rule requirements. We work with a third-party testing vendor. The core participants develop the test scripts themselves and approve them, and then organizations receive a seal that they can display to show that their product or system is compliant. One of the things we really encourage, and we have seen commonly over the past few years, is health plans and providers requiring their business associates to become core certified, because it allows them to feel additional confidence that their business associates are complying with HIPAA requirements that they are ultimately responsible for, given that business associate relationship. To date, we have awarded 406 core certifications, and they are all listed here. Some organizations have multiple certifications, and certainly you can go to our website, which has that level of detail to understand which specific operating rule sets these organizations have become core certified on. I'm also excited to share on the next slide that we've had a lot of activity already this year. We have 5 new participating organizations. So any healthcare organization can join CORE and contribute to the operating rule development process, participate in our subgroups and work groups, lead our subgroups and work groups as co-chairs, as well as just get the latest information on where the industry is in terms of data exchange and interoperability. So we welcome these organizations, as well as we've already seen 6 certifications and recertified organizations come through. Most recently, Alaska Medicaid and North Dakota Medicaid completed their recertification across multiple sets of operating rules. So congratulations to those organizations. Now I'm going to turn our attention, and this is where, if you decided to tune out for a minute because you're already familiar with us, I'd say it's time to listen again because this is updated information on the federal regulatory activity. So I mentioned before that CORE is the designated operating rule author under HIPAA. To have an operating rule become federally mandated, there's an entire process that occurs after the operating rules have been reviewed and approved by the CORE participants and the CORE board, where our board submits a letter to the National Committee on Vital and Health Statistics recommending a set of new or updated operating rules for federal adoption. And on the next slide, you can see our board submitted a letter back in May of 2022 with a proposed rule set, including updated operating rules. So these are rules that are currently federally mandated, but have had updates made to them for the infrastructure rules for eligibility, claim status, and remittance advice. And those updates primarily relate to system availability requirements. An updated core connectivity rule, the version that's currently mandated, is more than 10 years old. And as we all know, connectivity methods have really advanced in the last 10 years, and this modernizes that approach and would reduce the need for organizations to keep maintaining outdated connectivity methods, as well as updates to our eligibility and benefits operating rules, including data content updates that require organizations, health plans to let providers know whether a prior authorization is required, adjustments made for tiered benefits, and a plethora of other updates, including support for telehealth service eligibility and more detail at the procedure code level. Additionally, the CORE board recommended 2 new sets of operating rules for federal mandate, including rules for healthcare claim attachments and prior authorization attachments, both data content and infrastructure rules there. I'll put a pin in that one for a minute, and we'll come back to that because since this letter was first sent to NCVHS back in May of 2022, we've seen a lot of activity at the federal level related to both prior authorization and attachments, which my colleague will talk about in a minute. In terms of where we are in the proposed operating rule process with NCVHS, on the next slide you can see we talked about the letter has been sent. In January of this year, NCVHS held a public hearing to hear feedback from industry stakeholders, as well as put out a request for comment from the industry on the proposed operating rules. There was some really positive feedback and engagement from all types of stakeholders during this time frame. The next step is for NCVHS to make a recommendation to the Secretary of HHS on whether or not to adopt the new and updated operating rules. And NCVHS just published their agenda for their June 14th meeting, in which we are expecting that this recommendation will be finalized. Depending on the recommendation to HHS, if there is a recommendation to adopt any, all, or some of those proposed operating rules, that will trigger an expedited HHS interim final rulemaking process. I want to highlight here too, because this is relevant to most of our stakeholders as well, that in addition to operating rules being proposed to NCVHS, X12, which develops the HIPAA mandated standards, also proposed updates to 2 of their standards, the healthcare claims, the 837, as well as the remittance advice, the 835 transaction. So they went through a very similar process as you can see here. Also, these proposed standards were reviewed at the January NCVHS hearing, and they're looking at moving from the 5010 version of these standards to the 8020 version, or potentially a even newer version, depending on what is published at the time of the federal rulemaking process begins. So NCVHS has also indicated that they will be making a recommendation on those updates, those version updates to the standards at their June 14th meeting as well. It is a public meeting, so anyone can tune in to hear that discussion and the potential recommendations. So on the next slide, I'm going to turn it over to my colleague, Mike Phillips, again, Senior Manager at CORE. He leads a lot of our rule development effort, but also our policy work. But I want to highlight here some of the challenges around adoption related to prior authorization and attachments. And this is the reason that CORE developed attachment operating rules even before there was a standard named for attachments. What Mike is going to share is that CMS, kind of in the middle of us proposing attachment operating rules, CMS did propose an attachment standard as well. But you can see there is so much opportunity here for greater automation as well as time and cost savings across the industry. So Mike, I'll turn it over to you to talk a little bit about what's been going on at a policy level here.
Great, thanks, Erin, and thanks everyone for joining us today. Erin, you emphasized really well the federal action that's required to drive uniformity and automation, particularly across common electronic transactions. Before moving on to the next slide here, I think Erin teed it up quite nicely, but emphasize a couple of points on here that only about a quarter of a time are prior authorization and attachments carried out fully electronically, this data coming from the 2022 CAQH index. And shifting these transactions to fully electronic methods and avoiding the phone calls and the dreaded fax machine, we have the ability to save hundreds of millions of dollars and really a significant number of hours. I didn't do the math, but it probably totals up into literal days when you extend the per transaction savings to the total number that are conducted every year. Operating rules are really central to driving this automation, and NCBHS in the past has strongly recommended for voluntary adoption prior auth operating rules, and as Erin mentioned, rules for attachments are currently under consideration for federal recommendation of federal adoption. So moving to the next slide. We've covered some of this in a previous town hall, so I'm going to just kind of hit the highlights here. But CMS and Health and Human Services have been taking action, again, right in the middle of sort of consideration of operating rules to encourage the electronic exchange of prior authorization and to establish exchange standards for attachments. These are really two essential steps in promoting industry-wide adoption and automation of these transactions. Briefly, and beginning on the left-hand side, the CMS interoperability and electronic prior authorization proposed rule builds upon the interoperability and patient access final rule by establishing key provisions, including FHIR implementation guides for API data exchange. This includes requirements for impacted payers to maintain a prior authorizations document and decision API known as PARTI. And requires them to provide denial reasons, publicly report prior authorization metrics, and establishes timeframes, either 72 hours or 7 days, depending on the urgency of a request, where payers need to respond to a prior authorization request. On the right-hand side, the attachments rule is landmark in that it proposed the establishment of electronic standards and proposed two concurrent standards, one being the XBRL version 6020 of the 275 transaction, and the second being the HL7 CCDA. And the rule goes on further to establish standards for electronic signatures and also proposes conforming changes for the referral certification authorization for the from version 5010 to 6020 of the XBRL 278. So these are loaded rules, but that's really it in a nutshell there. But I want to go forward on the next slide to describe how CORE, and we issued responses to both of these rules to Chiquita Brooks LaSure, but go over our responses to these a little bit and go over a little bit of what we're seeing from the industry responses as well. For the electronic prior authorization rule, CORE really emphasized the importance of applying requirements across all payer types, and CMS exercising that authority under HIPAA to drive greater conformance and automation across the broadest population possible. We heartily support the use of emerging technologies and view APIs as promising in that area. However, we noted that use cases and incentivization of APIs should be aligned with infrastructure investments. And lastly, in response to an RFI included in that rule, a proposed rule, CHQH Core supported the role of standards in the uniform collection and exchange of social determinants of health, social risks, and really anything to advance data collection around health equity. And I'll cover a little bit more of that later while going over the accomplishments to date of the value-based payments subgroup. Industry-wide, we're seeing fairly strong support for APIs, but those who supported typically cautioned that real-world testing must be accomplished to ensure that these technologies are working as intended. Commenters also encouraged CMS to indicate implementation guide versions and other changes that make requirements clearer, so asking for broader clarity. Commenters were a little concerned, though, about prior authorization timelines, feeling that they may not sufficiently or adequately reflect clinical practice. Our team at CORE will continue monitoring closely as CMS responds to these insights and comments in the impending final rule. For attachments, CORE as a whole was generally supportive of the establishment of the electronic standard for attachments that are consistent with standard development organization guidance, but also leave room for iteration, realizing that this is a good starting point, but there may be room for future improvements or refinements as we gain more experience in the industry with these standards. Additionally, we also expressed our desire for our attachments operating rules to be adopted simultaneously to ensure that implementation is not fragmented. It's one thing to have a standard, the operating rules take that next essential step to ensure that implementation is common across all stakeholders. It's important to note that so far in our review that industry support for these proposals wavered, with many commenters expressing the desire to see HL7 FHIR-based standards included in the proposal. Additionally, other commenters expressed some concern over the implementation resources necessary to support two exchange methods simultaneously. As with the EPA rule, we'll continue monitoring the responses to the attachments rule, investigating how we can effectively address industry concerns through our work and our collaboration with our participating organizations and other industry stakeholders. So I'm going to pause there and pass it over to my colleagues to take us into the future.
Great. Thanks, Mike. If we can go ahead and move on to the next slide. Before we get into the details of the operating rule development that's occurring in 2023 at CAQH, I want to highlight some new resources that are available from our teams across CAQH that may be of interest to you all. First is a FHIR payer-to-payer data sharing issue brief put out by our Insights team. As a bit of background, in May of 2022, CMS released a series of proposals to improve the electronic exchange of data between patients, plans, and providers. And the Interoperability and Patient Access Rule outlines requirements for how plans must offer members enrolled in CMS-covered programs access to the healthcare data through APIs, and that includes really three parts: a patient access API, a provider directory API, and payer-to-payer data exchange. So within that payer-to-payer data exchange, the requirements is for payers to share a member's utilization and clinical data with a member's new payer. The process, which would occur at a member's request, requires CMS-regulated health plans to transmit patient data between each other when a patient enrolls in a new health plan. In this new rule, in the new interoperability rule that Mike just mentioned, CMS also proposes to require payers to use FHIR APIs to exchange this data between payers. So last November, CAQH's Insights team, and that's our research group, held a focus group with plans to better understand strategies and considerations for implementing this payer-to-payer data exchange. So the participants talked about their organization's overall interoperability strategy, resource considerations, and lessons learned to promote adoption and implementation. This issue brief summarizes the findings there. Overall, most payers in the broad healthcare industry seem to lack a well-defined interoperability strategy, particularly as it related to FHIR implementation. A lot of the plans indicated that they only update their workflows to fulfill CMS or other certification requirements, thinking of it more of a compliance exercise rather than a strategic decision. The timeline, so I guess one thing that was really talked about were implementation strategies as well. The discussion whether to build internally, buy, or outsource services to support the development of the payer-to-payer data exchange, or some combination of the both. And in the focus group, it was about an equal number of plans that implementing these strategies. They talked about the advantages and challenges with each. But really, regardless of the organization's approach, some of the challenges that emerged were around developing and communicating an API strategy organizationally, determining and allocating appropriate resources, securing patient data, and controlling for changes in versioning and requirements. And so what the group really came to the conclusion of is that as the industry continues to promote interoperability and engage with FHIR, the participants really suggested that sharing experiences and best practices is needed and beneficial to including payer-to-payer relationships to test data. So also engaging all aspects of an organization beyond just the technical implementation teams, including business analysts, operation teams, and clinicians, will really help drive that strategy from being just a compliance exercise to something that everyone across the enterprise is embracing and will help reduce implementation challenges. So encourage you to click the link if you're interested in more information. And I will now turn it over to Pete Benziger, our Senior Manager on CORE, who's leading a lot of our healthcare claims rule development efforts, to talk about our healthcare claims issue brief.
Thank you, Erin. I think that was a well-rounded overview of the FHIR issue brief. And in the healthcare claims issue brief, what we looked at was, pardon me, the very simple thesis of why in today's day and age, something that's plans, providers, vendors, et cetera, y'all on the line can empathize with, why is claim submission so difficult? We see initial denial rates as high as 12%. It's actually increasing according to Change Healthcare's most recent national denials analysis, if you can believe that. So because CORE looks at things through the lens of HIPAA mandated transactions, our mentality is, what are the root causes of increasing denial rates, for example, that can be addressed at square one, which is the currently mandated vehicle for claim submission, the 837. I'll be a little bit more brief here because we're going to get into exactly what the healthcare claims subgroup is focused on in a couple of slides. But regarding the issue brief and how it came to be, after a focus group last summer, a dozen interviews across a dozen organizations, including a survey, a couple different surveys to be frank, a guidance from the industry to increase clean claim submission focused on 3 areas that are outlined in the issue brief, and we'll go over again in a couple of slides. Very quickly though, those areas are telehealth claims, very prevalent across the last several years and very confusing if you are a healthcare biller. The 277 CA, that's the claim acknowledgement, as a complement to the 837, and the overall concept of how to submit 2 claims for the same encounter, specifically looking at that through a value-based payments lens. If you're doing that, for example, just to ensure that you're sharing as many diagnoses about a patient as possible, duplicate claims is an example of an initial denial that you might receive if payer guidelines, plan guidelines are not met. So please, as Erin said here, go in and click on the issue brief. We hope you enjoy it. We hope you enjoy our enthusiasm, I should say, about clean claims. Take a look at your leisure, and you know where to find us. We welcome your thoughts and enjoy opportunities to connect. Mike is going to take us through the 3rd issue brief on the right side of the screen. Should we talk about value-based payments, Mike?
Sure. Yeah. Thanks, Pete. So like Pete, I'm going to keep this somewhat breezy as we are going to go into more detail on value-based payment later in the presentation. But the VBP issue brief, VBP, value-based payment for short, really builds off the foundational work completed by my colleagues even before I joined CAQH Core back in 2018 that identified 5 operational opportunity areas that revolved around these concepts of data uniformity, interoperability, risk adjustment, patient attribution, and quality measurement, really not only integral parts of healthcare in general, but integral parts of value-based payment methodology. This work directly resulted in the development and publication of a set of patient attribution operating rules that are all available for voluntary implementation right now. In fact, the single patient attribution operating rule is currently being considered for recommendation of federal adoption by NCVHS. That leverages the X12 270-271 to return a patient's attribution status at the time of eligibility verification. The updated issue brief, once again, builds on this work by further confirming the importance and the relevance and frankly, the interconnectedness of the 5 operational opportunity areas I outlined before, placing considerable emphasis on this idea of data uniformity and technical interoperability as being the driving forces around many of the value-based payment methodologies, like risk adjustment or patient attribution. But this issue brief takes it one step further and acknowledges the developments over the last 5 years in this field, adding in considerations around the incorporation of health equity into value-based payment model designs, which is often accomplished through the collection of social determinants of health and other social risk data, as well as the complexity of program design and how that's increased over the last several years. I'll get into this in a little bit more detail later on, but given the sometimes modest or middling results of current value-based payment initiatives, programs have become more complex, almost out of necessity, to establish new priorities and to generate increases in quality or increases in monetary savings. The insights included in this issue brief were built off of a comprehensive environmental scan. I'm sure many of you on the call today were fortunate enough, I'll put it that way, to talk to me, Aaron, and my colleague Kayla Cooper in one-on-one interviews to learn more about your experiences with value-based payments. It was also built off of industry research. And just as a note that the conclusions drawn throughout the issue brief are directly informing the agenda for the CAQH Core value-based payment subgroup, once again, which will be covered later on in this presentation, the early accomplishments and the priorities of that group. So as with Aaron and Pete, I'll encourage you to click on the link, engage with it, and feel free to reach out to me. I'm always willing to hop on the line and have a coffee chat about value-based payments. I might learn something and you might learn something too, who knows. So at this point, I'm actually going to pass it back to Aaron to bring us forward into some of the rule development efforts that we're undertaking in 2023.
Great, thanks, Mike. So those issue briefs are a great introduction to some of the topics that CORE is really planning to touch upon in the coming year. So on the next slide, I talked a lot earlier in the presentation about what happens after the rules are developed and how they become federally mandated, but I didn't speak a lot around how the CORE participants develop the operating rules themselves. And that's really through a 3-step process. Both Pete and Mike mentioned the importance of environmental scans, helping understand where the pain points are within the industry, what are the priorities of our participating organizations, and once that's identified, then we move into the rule development process where we convene work groups that are chaired by industry representatives, typically a health plan provider and vendor, to actually develop the operating rule requirements. And again, that's a consensus-based process with lots of polling and balloting to ensure that there is strong industry support across stakeholder groups to move forward with the various requirements. Once the rules are drafted, we do have a formal voting and approval process with quorum and approval requirements at multiple levels to, again, ensure that there is broad support across the industry to move the rules forward for publication. Once a rule is published, organizations can begin implementing, and we'll build a certification suite to support implementation. This year, we have 5 priority areas for rule development. The first 3 are already underway, and Pete and Mike are going to talk about them in a minute, so I'm not going to go into a lot of detail. And then I'm going to talk about some partnership work we're doing with the standards development organizations to align our operating rule development with where industry is today and the needs industry has today related to payment and remittance enrollment, as well as medication eligibility. So with that, I'll turn it back to Pete.
Thank you, Erin. So turn the page here, and we shared a little bit about the issue brief earlier. Again, on the right side of the screen, as you can see, at the end of the day, CORE's goal is to streamline the business of healthcare. The transmission of the claim, depending on how you think about it, which has data about the services rendered, is at the front of that mission, because the claim submission, I should say, is at the start of the healthcare business process. So that being said, it is unfortunate that we're seeing increased denial rates, and a way that you could interpret that fact is providers and plans remain not aligned on how to submit claims. So we're pulling our resources together, y'all being the resources, I should say, and we have 4 co-chairs who help guide subgroup conversations and provide their own experiences and expertise to ensure our focus is on relevant topics regarding 837 claim submission. So Megan Sicorso is a representative from Gainwell, which is a vendor with a variety of different offerings. Mahesh Siddhanti from Centene, payer with multiple plans. Olga Kabinski is representing the Healthcare Business Management Association, as well as WCH, which is a healthcare billing and software company, and Randy Gabel from Ohio Health is a provider in the Midwest of the United States. If I could give you all a takeaway from this slide, other than the business challenge that we're all very familiar with, it should be that CORE does not do rule development by itself. The co-chairs play a crucial role in providing examples, industry context, et cetera, to the discussions so that subgroup participants can understand the relevance of the topic of conversation. And with the subgroup participants, I see a lot of y'all on the phone here. Hello, and thank you again for your participation. We all work together to develop operating rules that are high value to the industry. More on this as we turn the page. Examples of the topics in greater detail that we've previously mentioned regarding healthcare claim rule development are outlined on the right side of the screen. So far, in the healthcare claims subgroup, we have had 2 of our 4 scheduled meetings. And in the first 2 subgroup meetings, we discussed the need on how industry should align on identifying care delivery as telehealth using place of service and modifiers. As we all know, we saw a variety of different modifiers used to various degrees, to put it lightly, across the industry during COVID. An ideal outcome of this discussion in the subgroup here would eliminate confusion on the provider end to help plans know how to adjudicate a telehealth claim in a standard manner. So for example, questions like what place of service should we use, or what modifier should we use, anything in between there, are asked less frequently. We envision a world where those questions are asked fewer times or not at all, because there's an easy answer as outlined in an operating rule. We also discussed how to submit more than one claim for the same encounter. I gave a little bit of an example earlier as I was talking about the issue brief. This is an important topic because in the world we're living in, increasingly living in, I should say, where comprehensive care management and value-based payments are increasing in prevalence, providers and payers want to capture detailed information about their patients' well-being. On the currently mandated version of the 837, there is a cap on the number of diagnoses you can put on a single claim, if you will. I believe that number is 12. And providers sometimes want to communicate more than 12 diagnoses that they talk through with their patient. So the question that providers face and others face, frankly, I was talking to someone who had this discussion in an EMR implementation. How do you do something like submit 20 diagnoses without confusing a health plan? Turns out that health plans have standards for, hey, if you want to communicate more diagnoses than is allowed on a single claim, these are the steps you can follow. However, those steps are not standard across health plans. And as is the case in healthcare billing from the provider end, you do your best to keep up. We often, however, see that these instances result in a duplicate claim denial, for example. In our next meeting, which is scheduled, let's see, June 22nd at the bottom of the page on the right there, we plan to add the 277CA to the agenda. This is the claim acknowledgement transaction that when it comes back to the payer after submission, it can inform a provider of how to fix a claim that is coded incorrectly. The biggest current issue here, as we understand it from speaking with our industry colleagues, is that the information on the 277CA, specifically claim status codes and claim status category codes, can mean different things depending on the health plan. This is confusing, and it also makes the 277CA less useful. So we look forward to discussing how we can minimize confusion about what these claim status and claim status category codes mean, for example, and also make the 277CA more useful. Finally, a fourth topic of conversation that we will discuss in the healthcare claims subgroup is coordination of benefits. Our research suggested that the required data elements for primary and secondary claim submission are indeed outlined by individual plans and payers. However, they often vary from plan to plan. You can sense a theme here, if you will. Variances in required coordination of benefit claim data elements, they create additional administrative burden, using the phrase that we all hear so often. And we would like to eliminate that burden or reduce that burden to the extent that we can by agreeing in some capacity on what should the information that goes on primary and secondary claim, et cetera, or what should the correspondence between the two look like. It'll be a good discussion. We hope that it will result in reduced administrative burden regarding coordination of benefits. So we are very fortunate to have 85 individuals participating in the subgroup. I see folks on the line here, pardon me as I look away, from Epic, from Optum, Availity, a couple different Blue Cross plans, all participating in the healthcare subgroup as well. It's not too late to join. We'll share our email at the end of the presentation if you are as enthusiastic about cleaning claims, as I said, as we are. Do not hesitate to reach out. We would love for you to join in or at least connect with us, as Mike shared as well. I believe we're talking about VBP next. Does that sound right?
Sounds right to me. Thanks, Pete. Great overview of the healthcare claims work. I'm happy now, as I've alluded to several times throughout, about the value-based payments subgroup, which I'll acknowledge from the top is being led by three great industry leaders, all of who have spoken on core webinars in the past, and we'll soon be issuing a brief blog post detailing some of the progress to date in the subgroup. These three leaders are Michael Alwell from St. Joseph's Health in New Jersey, who is a vice president of revenue cycle, Naveen Maram at the Centene Corporation, who's the vice president of digital operations, and Michael Patwell, who I see on the line here today. Hi, Mike, from EdFX, who is a principal business advisor in value-based care. Operating rule development in value-based payments seeks to address the opportunity areas I outlined previously and won't rehash at this point, but also expand the impact and implementation of value-based payment models. And we think that this can really be summarized into 3 items that the operating rules can most effectively address. First is inconsistent data, which highlights how data delivery and format often differs between models and implementations. This is a major pain point and has been for several years, but it's a point too that complicates the collection and exchange of social determinant of health data that value-based payment models are currently using to help advance and improve health equity across the industry. The other 2 points related to limited results and program complexity are somewhat interrelated. As I mentioned previously, given the modest results of many demonstration projects to date, CMMI and other leaders in the industry have been somewhat forced to establish methodologies and shift priorities in value-based payment models that have the potential to result in greater impact, but also create a more challenging context for participants. CAQH Core can help address these issues, particularly the ones surrounding program complexity, through the establishment of a consistent infrastructure for value-based payment, as well as consistent industry terminology that can help lead to a common expectations and languages that are being used across industry stakeholders that could potentially ease implementation of these complex methodologies. Once again, and again linked here, are the reports in value-based payment for an in-depth appraisal of some of these areas. Moving on to what the subgroup has accomplished so far. At this point, we've had 2 subgroup calls with a 3rd happening just next week on June 8th. We're right in the teeth of planning for that. I'd like to acknowledge that the group, many of you are on the call today, has made tremendous progress in a short period of time and is currently seeking finalization of data content requirements for the X12-834 benefit enrollments and maintenance transaction that can increase the quality of sociodemographic and other data collected at the point of member enrollment into an insurance plan. Simultaneously, the group has been pursuing the application of semantic interoperability to value-based administration. Doing so, we hope, will help align industry vocabulary, which, as I highlighted previously, eases its implementation and contracting. We anticipate this will result in the production of a reference document that can serve as an industry standard and act as a glossary of sorts for current and future operating rules that will continually address value-based payments. Going forward, and to highlight topics on the horizon, the group will address infrastructure requirements as well as operating rule language for the X12-837 claim transaction that Pete did such a great job of describing earlier, and is being done in collaboration with the healthcare claims subgroup. So at this point, we're chugging along. We have over 70 participants from over 30 unique organizations. It's actually grown a little bit even since these slides were put together, so we're happy to have you all. There's always room for more, so please reach out to learn more about the requirements to join. On the next slide, the last item I'll discuss before passing back to Aaron and Pete to close us down for the day is the Code Combinations Task Group, whose responsibility it is to maintain and ensure compliance with core code combinations that are derived from base standard CARC and RARC code lists. The group is currently chaired by Lynn Franco from United Health Group, Heather Morgan from Aetna, and Tyler Scheid from the AMA. And the big news out of this group is that we have opened our biannual market-based review period, allowing any industry stakeholders who create, use, or transmit HIPAA-covered transactions to submit potential adjustments or additions or removals to the core code combinations. This survey or form, is linked on this slide, and it's open through to July 14th, so well over a month left to submit. And all these submissions will be considered and perhaps adjudicated by the Code Combinations Task Group for adjustments to the core required code combinations. As before, if you have any questions on this, please reach out to us. Happy to engage about this topic. I'm going to hand it back to Aaron now. So thank you all for your attention and for your engagement with our subgroups.
Thanks, Mike. On the next slide, I want to touch on two other rule development or update efforts that haven't yet been launched, but we are in the planning phase for. The first is updates to our EFT and ERA enrollment operating rules. You may recall that these rules are federally mandated. We developed them in partnership with NACHA, which is the operating rule and EFT standard entity within the financial services industry. These rule, enrollment has evolved as well as needs for security, particularly around banking information. And so we will be working with you all to understand how we can improve the data sets associated with these rules and continue to drive adoption of EFT and ERA transactions electronically. The second opportunity launching later this year will be a joint operating rule opportunity effort with NCPDP, which is the standards development organization that maintains standards and operating rules for the pharmacy industry. We are really excited to partner with them to develop requirements to support the exchange of medication eligibility information when it is covered under the medical benefit on the 270-271 transaction. So we are doing industry interviews. If you have thoughts on either of these efforts, we would love to hear from you as we plan for rule development later this year. Next slide. And then I briefly want to touch on some exciting information as well. If we keep moving forward, the CAQH Core Board has launched an effort to really think about who we are, revisit our mission and vision, and where we want to be in the next 2 to 3 years. Our environment is changing rapidly with emerging technologies and new regulations, and it's critical that CORE continue to meet its mission and help drive data exchange and interoperability across the industries. So if you have any thoughts or ideas or want to contribute to this process, please feel free to reach out. And we look forward to sharing our broader plans with you later this year or early in 2024. Finally, I'm excited to share on the next slide that CAQH will be hosting its first ever annual CAQH Connect conference, September 27th through the 29th in Washington, D.C. It is open to the industry. Registration is complimentary, and we will be hosting our first ever in-person CORE participant forum on that Wednesday for organizations interested in joining CORE or that are existing participating organizations. We already have a great lineup of speakers. Website will launch very soon, including our CORE board chairs, Anika Gardenhire and Linda Reed, a plan provider organization, as well as several other current and past CORE board members. So it'll be a great opportunity to connect with your colleagues and make a visit to the DC area. I'm now going to turn it over, Pete, to wrap things up and hopefully leave just a couple minutes for questions.
Yes, let's do that. Questions will be important. We have a few calls to action for you in the next 2 slides, so we'll turn the page. And here we have 3 webinar opportunities that we're very excited about. The first is in correlation with the NACHA initiative that Aaron just outlined, where the webinar will be led by, I'd like to think, the experts in healthcare payments. So that's exciting. Second is a discussion with our friends at HFMA about price transparency, an ongoing hot topic at the regulatory level. Patients are increasingly consumer minded when they shop for care. We're going to look at this topic through the lens of the provider. So that should be a good discussion as well. And third, our partners at CMS will join us to outline how operating rules support HIPAA standards. Going into a little bit of my own opinion here, operating rules, mandates, regulations, etc. They can begin to all sound familiar, especially if you don't hear them every day. So we look forward to clarifying that and adding additional color to the conversation. Hope you could join those. I know I'll be on them. May even see some LinkedIn posts from me about them. On the next slide, we'd be remiss not to share how you can become more involved with CAQH Core and where you can find us as well. You saw the new participants for CAQH Core right when we started the presentation, as well as those certified entities. We do have ROI assessment pilots that we like to partner with our partnership organizations on. I think we have a couple regarding attachments currently in flight. And even if you share a little bit of our enthusiasm about standard setting, we encourage you to stay tuned with policy development, submitting comment letters and the like as RFIs and NPRMs come out. That was a bit rapid fire, but we want to be certain that folks have the opportunity to ask questions if you got them. And I think that is the next slide.
Yeah, thanks,
Please.
Pete. Just a reminder, if you have questions, you can go ahead and submit those on the right-hand side of your screen in that questions panel. Looks like we have a couple that came through. The first one that I'll pose to the group and is if there are plans to consider more fire exchange in upcoming operating rules.
You know, that's a good question, and I think it's one that our answer is still we don't know, right? So earlier in the presentation, I talked about the definition of operating rules. Operating rules fill gaps in the standard. They cannot duplicate or repeat what is already in a standard or conflict with a standard. So as fire becomes more used across the industry and more highly implemented, we'll learn and we'll hear from you all as to how it's going and whether or not there is a need for operating rules. So we look forward to really the industry driving that decision.
Thanks, Erin. And before I jump into a registrant question, I see some notes coming in about the CHUH conference website link. I think they are currently working on getting that live right now. So if you're getting an error, we apologize for that. It should be up very soon. But yeah, let me go ahead and ask you a question that was posed by a registrant. Do you have any information on how the operating rules are being addressed by EMRs to ensure continued integrations across all EDI?
Yeah, absolutely. And of course, our lawnmowers just started mowing, so it's extra loud in here. But I will say regarding EMR implementation, if your EMR system is conducting the HIPAA transactions for you or any of the transactions adopted that have operating rules, we really encourage you to talk to your vendors about that, encourage them to become core certified. Particularly providers are reliant on their vendors to meet the operating rule requirements and ensure that that whole trading partner relationship and data exchange flows all the way from the plan to the provider, and the EMRs are critical to that. And in fact, you know, they sit on the core board for that reason.
Thanks, Erin. I have another question that came through, and Mike, this one is for you. How can we leverage administrative transactions and other emerging technology to better address clinical use cases?
Yeah, it's a great question. One is, and just sort of a general plug, always encourage provider participation on our subgroups. The more provider participation we have, the greater clinical perspective we can involve in those subgroups. And also stay apprised, as Pete mentioned, of any sort of pilot opportunities where you can help demonstrate the necessary ROI for these items. The other aspect to it is that we are somewhat beholden to data sets and the uniformity of data sets, of which there are many clinical data sets that capture things like clinical diagnoses through the ICD-10 to social risks through and other SOH through ICD-10 Z codes. Really starting at that foundational level and ensuring that that clinical data is transmitted in a standard capacity through the prevailing vocabulary that we have in the industry is certainly something that we can approach operating rule development, an angle that we can approach operating rule development from to make things more clinically relevant. But certainly can't emphasize enough the importance as providers and hospitals to really become involved with these subgroups. To contribute and share that clinical perspective. Hope that answers the question. I'm happy to engage offline.
Thanks, Mike. I think with that, we are actually just about at time. So if we didn't get to your question, we'll make sure to take a look at it after the call today. But thank you all again so much for joining us. And like Pete mentioned before, if you'd like to get involved in any of these initiatives, please feel free to email us at core@caqh.org. I hope you all have a great rest of your afternoon and weekend ahead. Thanks all.
Thank you. Thanks, Jackie.